Good evening. Very happy to be with you all face-to-face again. I will talk about the clinical experience with trifocal IOLs, TRIO IOLs. No financial interest. According to ECRS, most clinical trend surveys, cataract procedures involve presbyopia correcting intraocular lenses, and the most selected intraocular lens, according to the surgeons, are trifocal IOLs that we will talk now. I will talk one of the trifocal IOLs available in the market, which is designed for natural adaptation and has a brilliant light sensing system technology. It is TRIO because it has a refractive plus diffractive plus aspheric options, and the effective utilization of unused light energy up to 88%, meaning that, in other words, only 11% light loss results in an optimum asymmetric and balanced light distribution at each focal point. With this unique refractive and diffractive aspheric design, it supports angle alpha and kappa and minimizes halos and glares. Optimized 4 millimeters of diffractive zone reduces dependence on pupil size, and peripheral refractive zone supports the distance vision in scotopic conditions. It has a dioptric range from +7 to 30 diopters, but most importantly, we have the chance to use toric models to correct the pre-existing astigmatism up to 6 diopters on IOL plane or 4 diopters of astigmatism in corneal plane. With every single intraocular trifocal IOL, you have to be aware of the 3 characteristics of the IOL. The most important one is the diffuse curve, which provides a measure of the high contrast acuity of the lens at varying degrees of diffuse from plano. With this particular Optiflex TRIO lens, you have a good extended depth of focus for daily activities. The second one is the MTF function, which is a quantitative evaluation method used to measure the quality of optical systems, optical lens system, optical IOL. It is the value of the amount of contrast transferred by the optics, and with the trifocal IOL TRIO lens, you have an extended depth of intermediate, provides extended depth range of quality vision for daily activities. The third one is the chromatic aberration. Chromatic aberration creates separate focal points for the different wavelengths of light. But correcting chromatic aberration of the special intraocular trifocal lens restores sharp focus of the light waves. And the APA number, which indicates the amount of chromatic aberration, depends on the optical material of the lens. And with the high APA number of the TRIO lens, low chromatic aberration and high TMTF values are issued for the patients. Our TRIO study, the purposes are first, level of distance and near intermediate visual acuity of the patients, rates of spectacle independence, patient-reported visual symptoms, and safety profile. We had this is a retrospective case series consisting of about 500 patients, 554 patients. We could divide these patients for the cataract and the refractive lens exchange groups into 2 groups. When we look for the refractive lens exchange group for 73 patients, compared to the literature, most of them were female. The refractive error mostly hyperops, and the age range was between 42 to 73. And for the cataract patients, there is a strange issue that this trifocal lens can be accepted for the patients when implanted monocularly. This is very important for the patients, for trifocal patients, that you have a good topography and biometric data. If your K readings are up to 40s or below 40s, you can have surprising refractive results. Or if you have high axial lengths or short axial lengths, you can have surprising results, and our results are in normal range. The Q value, RMS and spherical aberration and angle kappa values are just for dealing for refractive results and halo and glares. You have to have a good topography in order to select the good candidates for the trifocal IOL, which is Q value, RMS, and chord value, which gives us the angle kappa. Importance of aberrometer is another issue for the trifocal IOLs. Of course, you have to have a good pre-op retina evaluation and with OCT, and especially PVD, pre-op PVD, and post-op induced PVD is a remarkable option for your follow-up patients for trifocal IOLs. We looked for the biometric results, and with the refractive results, we compared both those issues, and we have a good, excellent biometric compatibility with this particular trifocal lens. And the SRKT and Barrett formulas are much more comparable to the refractive results for this particular lens. For every trifocal IOL, you have to have post-op ametropia for having a happy patient. And in our study cohort, post-op spherical and cylinder refractive accuracy was within acceptable results for 93% of the patients. Visual acuity at 6 months, near, intermediate, and distance are very good, and spectacle independence is achieved for both eyes implanted surgeries. And in 95% of the patients in whom underwent binocular implantation had binocular cumulative uncorrected distinct visual acuity of 20 or better in our study. Of course, the main issue is glare and halos for the trifocal IOLs. And we have, in our study cohort, all patients had somehow halos and glare, all of them. But only 1/4 of them, approximately 25% of them, had quite annoying or very annoying halo and glare symptoms. What you should do with managing glare and halos? The patient must have been informed about this ahead, before the surgery, and you have to select the best candidates regarding managing glare and halos for the trifocal IOLs. At the 6-month follow-up, we didn't have any IOL explantation, no significant tilt or decentration. The PCU value was a little bit higher, 2% approximately. No non-uveitis, non-endophthalmitis. But you have to be aware of pyramid study when dealing with a patient with trifocal IOL with diabetic patients. And we have to be aware of myopres study that high myopia, high axial length, and male gender, and post-op induced PVD is a risk factor for retinal detachment after the surgery. My way for trifocal IOL recommendations are shown in the slides. The patients shouldn't have no corneal and retinal pathology. First recommendation is bilateral cataract patients, and second for clear lens exchange patients above 45 years old, hyperopia, and also presbyopia. But these trifocal lenses can be accepted and well tolerated when implanted monocularly too. But if you have a pre-existing astigmatism over 1 diopters, please use toric models, and I strongly advise flex femtolaser-assisted cataract surgery for CLE patients. In conclusion, optifocal trifocal IOL is a good alternative for the existing trifocal IOLs. With the right patient selections, it provides needed specular independence and with minimal level of disturbing photopic phenomena for cataract patients. This is a short video, and I thank you all for your patience.
So while the video is running, thank you very much for the nice presentation. I personally do like it as well because it has less rings at the outer side, and I can really, what you saw, that patients don't have so many photopic phenomena in comparison to other multifocals. I think that's a very good argument. But I would say, while the video is running, or ask Dr. Ankur Barua and Professor Hosni to make their final comments on the products.
You could, because you use these lenses. So.
I am a big fan of the Trio lens, actually, and one of the things that strikes me with this lens is that it really gives a continuum, of vision, unlike other trifocals where patients, see far, see intermediate, and see near, but there's a blur in between. This lens gives you quite a continuum vision, so I really like it. I was just telling Ankur, the last patient was a very high-profile professor of electronic engineering, and he goes to Japan, comes back, and he's over the moon. So I do like this lens.
Yes, and also it's a very user-friendly lens. During the surgery, the lens is very tolerated during the surgery for centration.
And I saw you nodding when you saw the MTF curse. I saw you nodding. That's what you're talking about. That's a continuous application of good vision. Do you have a final word?
Final word. In terms of, have you used the EDOF as well? Do you use both lenses or just the trifocal? Do you use the EDOF version as well, the depth of focus one?
No. This is not a comparative study. We just give the results of our clinical experience for trifocal IOLs.
Yeah, because my experience is when you're comparing between the two, sometimes you do mini monovision with the EDOF, but with these lenses I find, with all the trifocals, if you choose a patient right, then they do very, very well, much better than the EDOF group. Yeah,
the main issue is to select the best suitable candidate for the trifocal IOL, especially for the halo and glare, for the dysphotopic phenomenon. And it's well tolerated when you implant a trifocal IOL for monocularly. Yeah. The other eye is phakic, or the other eye is implanted monofocally, but should have 20/20 vision at distance.
Thank you.
It's well tolerated.
Thank you.
So thank you very much to all speakers and to our expert panelists. I think there would have been, if we would have had more time, we would have loved to discuss more, but it was tightly packed. So on the other hand, you had a lot of information in a short time. Thank you very much, Biotech, for bringing us all together and for really providing us with very interesting products. Thank you very much.